normal fast, but you take a hit.
They just wait till it melts here.
Yeah. Here it turns to slush, just black slush in about 8 hours from now. All right, looks like Dr. Szerlip came in.
Can you guys hear me okay?
Yes.
Yeah, how you doing?
I'm in my VA clinic. Nice. My video doesn't seem to be working. I think my Wi-Fi is not very good here, so I'm trying to make sure.
Okay, if you want
something to work.
Who's presenting, or who's going to give who's going to kick off?
So we're going to start with Dr. McGrath. So here it's 4 o'clock. Why don't we get started? So welcome everyone back to another edition of Tumor Talk. This is the joint collaborative effort between Lenox Hill Neurosurgery, the Journal of Neuro-Oncology, where we talk about recent publications and the reasoning for the study, the results, and the relevance to tumor surgery. This is continuing with a special award series that we've been doing really throughout the year, where we're looking at award-winning abstracts, and today's focus is on neuro-oncology and spine. And these are our award winners. So without further ado, we're going to welcome Dr. McGrath, Dr. Lack, and Dr. Szerlip. And we're going to get started. They're going to each present for about 10 minutes or so. We'll take questions from the audience as usual and the panelists. We'll start with Dr. McGrath. Why don't you guys each individually introduce yourselves as it's your turn and take it away.
All right, will do. As Dr. D'Amico mentioned, with another Dr. Yad, I'm a medical student in Columbus, Ohio, working with Ohio Health on some racial disparity projects, particularly with astrocytomas of the spine. So again, thank you for having me on board today. I'm grateful to be presenting. So the project we had was relationship between race and survival rates of spinal astrocytoma patients. This was a 20-year observational study using the SEER database. And oops, there we go. So no disclosures to report here. So just a quick overview of spinal astrocytomas in general. So astrocytomas are a subtype of glioma. Gliomas are the most common spine and CNS tumor. These are broken up into 4 grades based on the 2016 WHO classification system. Grades 1 through 4 are some of the more common ones you hear about. Grade 1 polycytic astrocytoma, and grade 4 glioblastoma multiforme. It's important to note that up to 93% of astrocytomas are WHO grades 1 and 2, so most of these are lower grade tumors, and median survival ranges vary widely with these tumors depending on the grade. So for grade 4 classically glioblastoma, the survival rate is median survival rate is less than a year, and then for grade 1 astrocytoma is greater than 10 years. So moving on for primary spinal astrocytomas, as the name implies, not arising in the brain but in the spinal cord. Reported incidence in the literature is about 0.2 per 100,000 individuals. That comes out to about 700 people per year in the United States. They account for 68% of all spinal tumors, and they're predominantly located in the cervical and thoracic spine. And on imaging, MRI findings of these, as you can see to the left here, they typically demonstrate hyperintensity on T2 weighted images. Here to the left, there's a T2 weighted sagittal cut of the cervical thoracic spine, and you can see down at the bottom of the screen here, there's a small hyperintense lesion suggestive of what you might find in a spinal astrocytoma. So mainstay of treatment includes surgery and can include radiation. Some studies have demonstrated that including both surgical resection and radiation can increase survival in these. And again, as we mentioned, median survival varies widely, even for spinal astrocytomas, depending almost exclusively on the grading. So moving on, what is SEER? So SEER, the Surveillance Epidemiology and Results Program, this is a cancer database put on by the NIH and National Cancer Institute. As the name implies, it is a surveillance database for cancers of all different kinds in the United States. They collect data on frequency and rate, survival, incidence, things like that. SEER Stat is a statistical software program that is free to download and use from the SEER website, and allows you, any user, to register and use it and compile cancer data regarding survival and incidence, similar to how we did in this study. So for this study, the purpose of this study was to serve kind of as a pilot a pilot for future studies, as I'll get into. But basically what we wanted to do is kind of look at an overarching view of incidence and survival trends across 2 decades for spinal astrocytomas. Looking at spinal astrocytomas of all grades with respect to age group, gender, and race from the 1990s through the 2000s. And that data was reported, aggregate data across 2 different decades. And when we talk about race in this abstract, in this presentation, we're referring to Caucasian, African American, and then the way SEER groups some of this racial data is those 2 groups making up most of the data that we pulled here, and then other races, including American Indian, Alaska Native, Asian, and Pacific Islander, all collectively. And then when we discuss cause-specific survival here, cause-specific survival as a result of this tumor is reported in 12-month intervals up to 5 years. And we classified, for the purposes of this abstract, classified short-term survival as 12-month survival rate, and then long-term survival as 60-month. So I don't expect anybody to be able to read this very clearly, but these are just a couple screenshots of what this software looks like. There's a bit of a learning curve on how to use it, but once you train yourself on how to use it, it can be very useful in pulling data on all different types of cancers. Yeah, so in results, when we look at incidence in relevance to age and gender breakdown, we do see that from 1 decade to the next, the reported incidence of this tumor more than doubled. At first glance, you might think that this is a reflection of maybe an actual increase in incidence of this tumor. We don't believe that's the case. When looking at the distribution of this tumor among different age groups and the male and female population, we do see that it's relatively consistent. As you can see here, 88 to 90% of people having these tumors are below the age of 60, which is pretty consistent with the literature, as well as the total percentage of male and males under the age of 60. In the literature, these tumors are classically found in males under the age of 60. And we see here that over 50% of all of the data that we pulled was consistent with that. And then looking further into racial breakdown of the incidence of this tumor, we do find that, as the literature also suggests, 77 to 80% of these of patients diagnosed with this tumor are the Caucasian population. And then these are just 2 graphical representations, kind of showing, something that's a little more visibly friendly. We do see that predominantly this tumor does occur in, as I mentioned, under the age of 60, with the most common age group being 0 to 19 years, and also predominantly in the Caucasian population. Okay, moving on to survival data. So this data was interesting that we found. Again, this was just overarching trends. These are just raw numbers. There was no statistical analysis being done because, as you can see, the power of this study was relatively low over the course of 20 years. But we'll get into future direction and things like that later. But if we look at survival data, just raw survival data for this tumor, we do see what you might expect. That short and long-term survival does improve, or has improved, from the 1990s to the 2000s, as you may be able to reasonably expect with improving screening and management protocols for this tumor. And what we did find interestingly is among all of the populations that we studied here, African Americans did see a 10% decrease in short-term survival from 1 decade to the next, despite presumptive improvements in screening and management. Additionally, we found that the other racial population collective group that SEER organized showed that 45.5%, they showed a 45.5% survival rate long-term, which was the lowest survival rate that we found in this study. And also moving on from 45.5% in the 1990s to the 2000s, they did experience the greatest margin of improvement. The margin of improvement was about 28%, as we can see in the 2000s was 73% survival rate long-term. And I apologize, this graph may be kind of confusing, but it was the best way to organize two decades of data. We see here all races, and then broken down by each different racial group. We see the orange line is the 1990s, survival rate extending from 12-month to 60-month, and then the blue line being the 2000s. We see that, as we may expect, survival is going to increase overall across all races from one decade to the next, and we can see that being reflected across just about every population except for here, where we see short-term survival of African American population decreased. And then finally, as I mentioned, the margin of improvement here with the other Asian descendant populations improving quite drastically from one decade to the next. So these results raise some interesting questions. Spinal astrocytomas appear to arise in Caucasians disproportionately. As we mentioned, it was about 78% Caucasian. That is reflected in the literature, whether that be because of some documented genetic components associated with astrocytoma, whether that be neurocutaneous disorders or other different genetic primary and secondary mutations that are more common in the Caucasian population. Or it raises the question of this is a reporting database. This is administrative data, and only cases that get seen by a physician can be reported. Which brings us to our next point: is despite improvements in management and screening, African Americans witnessed a 10% decrease in short-term survival. And when we look at this tumor being predominantly low grade, most common presenting symptoms being pain, new onset neurologic dysfunction. Patients who are less likely to see a physician for new onset symptoms, are, as one can expect, less likely to survive from this long term, and maybe even less likely to report the tumor altogether. And this trend of decreased survivability is one that's fairly common in the literature. I'll talk about a couple studies here. I won't take too much time, but this is an interesting SEER study that was done not long ago that studied the same time period that we did, looking at several major cancers. Ultimately had a patient cohort population of 1.02 million. And they found that African Americans experienced poorer survival than Caucasians for all cancers studied. And that disparity, that gap in survival rate was consistent for all cancers except for prostate and ovarian. The disparity improved for prostate cancer over the course of 20 years, but actually widened for ovarian cancer. And these two other studies are also SEER studies demonstrating very similar concepts that the non-Hispanic Black population typically experience higher hazard ratios and all-cause mortality rates for certain cancers, depending on the study. But these studies, as you can see here, are fairly large patient populations, and I think are worth discussing. So in conclusion, we believe that I think that this study demonstrates that SEER is an effective and useful tool to study cancer population data. As I mentioned previously, this study kind of served as a pilot study. What we plan to do moving forward is gathering additional data, particularly from the most recent decade when that data becomes available, with hopes of increasing the power of the study, and also incorporating geographic and socioeconomic data with this survival and incidence data, because we believe that may play a significant part in the survival disparities among different races. And some limitations, as I mentioned, but yes, thank you very much. Again, I really appreciate having the opportunity to speak about this.
Thanks so much, Kyle. Dr. McGrath, you'll be there. So great job. I think you hit the nail on the head. I think obviously further research is necessary, but the idea here is that, or at least what I see when I look at these data, is that people who aren't diagnosed early aren't doing as well. Overall, it does look like we've made some progress in a very tough disease. But there's obviously, problems in the system of medicine that need to be addressed to ensure that everyone's getting diagnosed appropriately and treated appropriately. Jason, anything to add before we move on?
No, I think in the interest of time, we should probably move on to the next speaker. But Dr. Lack, I think you were going to speak next. But I think the study shows the utility of the SEER database for studying these rare tumor types, and obviously looking for racial disparities in outcomes is important.
Always, yeah. All right, Dr. Lack, introduce yourself. Tell us about what you've done.
Can you see my screen?
It's coming on now, yes.
So thank you, Dr. Dimeko, Dr. Sheehan, and the GNO team for giving us this opportunity. My name is Asad Lak. I'm a research fellow at the Brigham and Women's Neurosurgery Department, and I'll be speaking today about our study looking at the trends in utilization of radiation therapy modalities in the management of spinal metastasis. I have no disclosures. So as we know that an estimated 30 to 60% of all cancer patients are estimated to develop spinal metastasis throughout the course of their disease. And based on the current treatment frameworks, one of the most common being NORMS criteria, radiation therapy is recommended for symptomatic, uncomplicated spinal metastasis. And within the radiation therapy modalities, conventional external beam has been traditionally the standard of choice for pain relief and local tumor control. But as the cancer incidence and the systemic treatment options for primary tumors are improving, the patient's life expectancy is increasing, and that demands a need for a treatment modality that offers better local control and better pain relief. And that's where the stereotactic body radiation therapy has been gaining control over the last few years. So our objectives were to look at the national trends in utilization of different radiation therapy modalities for spinal metastasis. And we also wanted to see if stereotactic radiation therapy improves any survival outcomes in these patients. And in order to answer these questions, we relied on the National Cancer Database, which is a jointly sponsored database between the American College of Surgeons and the American Cancer Society. And it is comprehensive in a sense that it comprises more than 70% of all newly diagnosed cancers in the United States. But it also has some limitations, some of them being that it only records data about the initial presentation and the first-line therapies. And in terms of metastasis, limited data is available, but when you couple the available data with the type of radiation delivered and the target, we can look at the radiation to spinal metastasis. And in terms of survival analysis, it only provides overall survival. So we queried the NCDB from 2004 to 2016 and included all newly diagnosed stage 4 cancer patients who required radiation therapy. And based on what's currently published out from the NCDB, we used a 30 grain 10 fraction as conventional external beam, whereas 15 to 30 grain 1 to 6 fractions as single fraction or hypofractionated stereotactic radiation therapy. And the trends in utilization of stereotactic radiation therapy versus conventional external beam radiation therapy were looked at using a multivariate logistic regression model. And for survival analysis, we used the Cox proportional hazards model. And in order to reduce the false positive rate, we use a p-value less than 0.001 as statistically significant. This table represents the total number of patients included in our study. We had almost 35,000 patients with lung adenocarcinoma, small cell lung cancer, and prostate cancer being one of the most common tumors in our study. And this bar graph demonstrates the trends in utilization of different modalities throughout time. So the y-axis represents the percentage utilization of each modality, and the x-axis represents the time interval. So the bottom left would be 2004, and this would be 2016 on the bottom right. And as you can see that the receipt of stereotactic radiosurgery, either hyperfractionated or single fraction, that is demonstrated by the blue colors, and the red colors is increasing over time, whereas conventional external beam has been less used. And in our regression model, we identified that the stereotactic radiation therapy was more likely to be administered in academic or comprehensive cancer care centers as compared to community hospitals. And also that patients who were elderly or those who had higher comorbidity index were also more likely to receive stereotactic radiation therapy as compared to conventional external beam. And the receipt of utilization of stereotactic radiation therapy varied by geographical location and primary tumor, but it was independent of the patient's race, insurance status, or the patient's sex. And in survival analysis, we did find that single fraction SRS was independently associated with improved overall survival after adjusting for patient characteristics, care type, care setting, tumor type, and systemic treatment. And when we analyzed the overall survival by tumor type, we did find that overall single fraction improved adjusted overall survival for lung adenocarcinoma and renal cell carcinoma, whereas for breast, colorectal, and other tumor types, there was no statistically significant overall survival benefit. And overall, uninsured patients and those patients that were managed at community settings had worse overall survival as compared to those who had private insurance or those who were managed at academic or comprehensive care setting hospitals. So in conclusion, despite the limitations of registry data, we believe that by using rigorous variable design and analysis, we were able to evaluate the national trends and practice patterns associated with stereotactic radiation therapy and conventional external beam. And based on our findings, we did conclude that patients treated at academic or comprehensive care centers are those who had higher comorbidities, and elderly patients were more likely to receive stereotactic radiation therapy. And we believe that future research is needed to identify the obstacles that are faced by community hospitals in providing stereotactic radiation therapy. And interestingly, in line with the findings from the recent SABRE-COMET-1 trial, we did find that single fraction SRS did provided an overall survival analysis. But we think it would be interesting to have further research to identify how is the relationship between single fraction SRS and overall survival, and whether the durable local tumor control provided by stereotactic radiation therapy leads to a rapid return to systemic therapy, which then leads to a survival benefit. And I would like to just thank my colleagues and mentors, Dr. Smith and Dr. Gillespie, and any questions I'm happy to answer.
Yeah, I mean, clearly an important topic and one that is very impactful for so much of the audience for Journal of Neuro-Oncology, for neurosurgeons and radiation oncologists, and for that matter, for medical oncologists. So I think you've raised awareness of the growing trend of SRS and SBRT and really broken it down nicely. So much appreciate that. And, again, all award-winning talks, so fabulous.
Yeah. Dr. Szerlip, you want to give it a shot to see if you'll be able to share your slide deck?
Let me just comment on that last talk, because I think it is near and dear to neurosurgeons. You know, and it's a huge difference I found when I went from a more community to starting a program at Michigan. It's a fight as a neurosurgeon. It's very frustrating when you can't get SBRT and you're trained in this algorithm of SBRT, and then the radiation oncologist won't do it. So it really does depend on having the buy-in from the medical oncologist and the radiation oncologist when you build a spinal oncology program. And I think that's one of the most important things in building a program, is to get everyone to buy in. And I wonder if the single fraction differences you're seeing in overall survival are related to the types of tumors that they're giving single fraction to. You know, we give single fraction really to bone-only tumors that are really not near the epidural space, where we do 3 fractions. So I wonder if there's a way to look, you know, maybe those patients are a little worse off. There's more tumor burden. There's more closer into the epidural space, which will, I mean, it wouldn't probably affect overall survival, but it does indicate more disease. And obviously,
that's an excellent point. Definitely. I'm sorry, Jason. Tim Smith here. I think that's an excellent point. One of the limitations is using this data set is that we really don't have access to any resolute data regarding imaging. So that makes it a challenge.
Yeah, I'll put in a shameless plug for the tumor section meeting in Austin. The very first special session that kicks off the 2-day meeting is on spinal oncology, and the very much of the focus of it is on spinal metastasis and our management of those. So please do take a look at what's on the website, and for those interested, registration and abstracts. The call for abstracts is now open.
Do you guys see my screen?
Thanks, Jason. Yeah, we can see it.
Sharon. Okay, great. Because this would be a very hard talk to give without slides, and I apologize again for the video. So this is, you know, born out of kind of on the basic science side, taking a step away from the clinical stuff. I'm the head of the spinal oncology program here, and trying to think about spinal oncology is what kind of problem it is. You guys described it very well. Thousands, hundreds of thousands of people have osseous disease every year, metastatic disease. And if you really look at it and break it down, way more disease goes to the spine than the bones, the long bones. And so this comes out of, well, why is that? And if you look at even prostate cancer, some of these like 60-40 prostate can actually be up to like 70 to 80% of lesions are in the spine, as opposed to the appendicular skeleton, the long bones. And so we wanted to kind of get at that biologically and see if there were reasons for that. So what do we think the increase is in incidence? What's the old reason? It really goes back to like 1800s, 1900s, to the seed and soil hypothesis by Paget. And it's either tumors are going to the spine more, like the cells want to go there more than they want to go somewhere else, or there's a permissive local microenvironment, meaning that once they get there, they're going to grow better. And so there's some animal studies that show if you inject, there's a lot of studies that show there's more tropism maybe to the spine, But there's animal studies that still show this, the more predilection of the spine, even though when you inject, they go everywhere and there's equal incidence of cells. And obviously there's some increased vascularity to the spine that can get it there. But once it's there, it still probably grows better. And so why would it grow better in the spine than the long bones? So we kind of want to say, well, what's different about the spine microenvironment than compared to other bones? Obviously, there's differences in red marrow volume and things like that, but people have been looking for many years to try and find local differences in cell populations and really haven't been able to find some. It's not in this talk, but we've actually have found some immune cell population differences in spine versus long bone using advanced cytoff methods, but using FACS and things like that, it's very hard to find differences. But one key feature of the spinal skeleton that's different than the long bones is the dura. And like, how different is that? Like, it's really hard to think because most people are like, well, the dura is not really that close to the spine, but this is an H&E stain of a spine of a mouse. And you can see that here's the cortex of the vertebral body, and the dura lies really right next to it. There's really no difference. In some parts of the spine, you're going to see the PLLs between the dura and the bone, but the PLL is mostly in the center of the vertebral body. You know, when we operate on it, you see that. And it doesn't really expand off the top, the whole back of the vertebral body. So there's a lot of areas of the vertebral body where the dura is in direct contact with the vertebral body. And there's a lot of these things called vertebral foramen, where you look at a microscopic level, where the dura and the bone marrow in the picture on the right are directly interfaced, where the bone marrow cells themselves are directly lying against the dura. And so then we thought, well, this lies pretty close. If the dura is affecting the tumors themselves, and this talk we're just looking at the direct effects of dura on tumor, not dura on microenvironment. But you would expect then tumors to grow closer to the dura in that area where they get the cytokines or whatever. So we looked at 200 patients, 233 lesions, and said, well, where do most lesions occur in the spine? Anecdotally, as a neurosurgeon, I know they occur back there because that may be selection bias because that's one we see. So we looked at all of our SBRT patients over a couple of years and just said, well, regardless of whether we did surgery or not, where are these lesions? And mathematically, you see a huge preponderance to have lesions start in the back and move forward. So there's very few lesions that just happen anteriorly and in the middle. When these are mostly big lesions because obviously we treated them. That's how we got these patients. So most of them are in the posterior middle or posterior, middle, and anterior. So, but you can see a mathematical trend, actually is statistically significant, but it starts from the back and moves forward. So which supports maybe there's something going on with the dura and lying right there and feeding it. So we took mouse dura and we cultured it and said, well, what kind of cytokines is this thing making? What does the dura do to the tumor cells themselves? So we just took and cultured the dura, took what we call dura conditioned media, and then said, okay, does this have an effect on tumor cells? And we chose prostate because prostate is one of the most common ones. We looked at, this very lot of busy slide, but growth, migration, and invasion of 5 different prostate lines. And we saw pretty much statistical significance, increase in growth, increase in migration, increase in invasion with all the prostate cell lines. There was a couple that were like just missed significance, but it really did have an effect on everything. And so then we wanted to say, well, what could we be producing that would have an effect? So we did some RNA sequencing and then just cytokine analysis. And we kind of looked at all the cytokines, and we looked just the one on the left is dura conditioned media, and you see CXCL1, CCL1, IL-6, IL-10. And then we looked at bone marrow itself and compared the differences between the vertebral bodies and the long bones. And so what really comes out is the CXCL, CXCL2, CXCL1. That's the dura makes a lot of, and if you look in the bone marrow itself, those levels are much higher. So we kind of focused on the receptor for CXCL1, 2, and also 5 and 8. They're all the same receptor, the CXCR2 receptor. So we wanted to see if this pathway was one of the predominant effectors of this growth and migration invasion that we see in these prostate tumor cells. We did a few other cell lines as well that also were equally affected by the dura, but we just focused this stuff on the prostate cell lines. So first we want to see, well, do prostate cell lines have CXCR2? So we looked at that, and most do to variable degrees. PC3s, which actually is the most studied prostate cell line of metastases, actually has the least CXCR2. But the CXCR2 literature that is actually published is all based on PC3s, which actually do not, it's a very kind of hard cell line to work with. It's kind of a dirty cell line. If I had a PC3 line and you had a PC3 line, they're usually not the same. They don't always express the same thing. So it's not the cleanest line to work with, but it's got the least amount of CXCR2 expression. And this is by FACS and analysis. The Westerns on CXCR2 do not work that well, so we stuck to flow analysis. So then we said, well, if this has CXCR2 and we're releasing a lot of CXCL ligands that affect CXCR2, then let's try to do an inhibitor and see if we can inhibit this and see if it inhibits these reactions. So we used a selective CXCR2 inhibitor, and then here we can see that you abrogate the growth in not PC3s. It's a complicated one as well. I don't even have the key in front of me, but for the most part, you abrogate the growth in everything but PC3s. This is the Dura, the normal one. The conditioned media is the rectangles, and the Dura conditioned media is the black. So here you see a growth increase, and you'd want to see that the triangle ones with the Dura conditioned media and the inhibitor come back down to the DMEM, the normal media. So you don't see that in PC3s. You do see that in the D145s, the 22RB1s, the LN caps, and the R caps. I think, yeah, and then you look at migration and invasion. Migration is the same thing. You get abrogation of the migration seen in most things. And invasion, we do not. So invasion, we don't see abrogation of the invasion with the CXCR2 inhibitor. So for the most part, the dural have a direct effect on the prostate cell line, increasing growth, migration, and invasion. And some of that effect is related to CXCR2, but not all of it. And actually, like I said, if you look back at the PC3 literature, for some reason, if you go back to PC3s, the invasion is actually abrogated by a CXCR2 inhibitor. So the old literature actually suggests that all the CXCR2 is done with PC3s, and it says that states that CXCR2 and CXCLs actually affect invasion. But we actually found that only in one cell line do the CXCLs affect invasion. So it's probably some other ligand of the Dura that actually is affecting invasion. And so we see more reaction to the CXCR2 receptor in migration and growth than we do invasion. But we at least see the growth migration in the CXCR2, and it does correlate to the higher CXCR2 expressed cell lines seem to have a bigger response. And there's also some differences in the androgen receptor sensitivity to some of these. And there's been some link to CXCR2 and androgen receptor responsiveness as well, but we have to kind of ferret that out more. So we have a lot more to do. So we have to do some functional data now to see, this is in vitro. So now we're developing an in vivo model. And this is just some mouse stuff that we just did in differences of cell growth in vosicles and ossicles. So this is a vertebral body, the vosicle, and ossicle is just a long bone. And if we just grow them, these are black 6 mice. So if we just grow them, we see that there's definitely an increase in growth in the vertebral body model. This is a direct tumor injection into the vosicle, then we implant them sub-Q, so they have bones. And then eventually now we're gonna do some CXCR2 inhibition in these mice and see if we can get these to equalize. So the hypothesis is that if CXCR2 is important in these growing, that if we inhibit the CXCR2, then we should abrogate this difference that we see here. So that's to come. We just finished this model this week, so this is just new stuff that is not really included in that abstract.
Fabulous work, and I think you've demonstrated very compelling data in the cell lines that you've looked at, and obviously translating this into an animal model and pursuing it further is the next step. Obviously, love to see if this same sort of cytokine driver and inhibition of the same could block other types of metastatic cancer involved in the spinal too. I suspect it can.
Yeah, and there's a lot of literature on breast cancer and CXCR2. And so the more they look, the more they're finding CXCR2 is in a lot of cancers. And so I think it will be a lot. I think it will look pretty good in all different histologies. And the other line of research we're doing that's not included, this is the effect of the dura and CXCL, the CXCLs on the local microenvironment. And what we've found thus far is that, it really increases the MDSCs and the immunosuppressive ability, the immunosuppression environment of the vertebral bodies compared to the long bones. And so CXCR2 could be a much larger target, not just in direct effects, but indirects to set up that immunosuppressive microenvironment.
Fantastic work, fantastic model too. I guess there's obviously more work to be done on it, and but it seems like you have a good system, a good framework for that. What do you think is more important, addressing the growth or addressing the invasion? I mean, I guess it changes where you would put your therapeutic eventually, right?
It depends on when you're giving the therapeutic, I think, too. So we have not been, a metastatic model of any cancer in a mouse has not been very effective. We've tried cardiac injection, the chances of it going someplace. So these are direct injections. So it's really focusing on late. So I think you got to get the cancer before it grows too big, because I think it's in the early stages. And you want to make, but there's also a reciprocal effect that we've seen with CXCL5 and CXCL2, where that once the cancer is growing in the vertebral body, it actually upregulates the dura release of those cytokines by like 5 or 10-fold. So you do want to catch it early because it has there's like an autocrine loop, it's a reciprocal autocrine loop with the tumor and the dura itself. So it becomes, and the dura is made mostly of fibroblasts. So I think you're creating like a tumor fibroblast environment, and the fibroblasts are already there. So they don't have, so it's already the environment, the tumor microenvironment already exists in the spine at baseline. And that's kind of what we're finding.
Great work by everyone. We're at our 30-minute mark, so I just want to say thank you to everyone for coming along. Like I said, the talk will be posted on our YouTube station, the JNO YouTube, and I can send a link to everyone as well, so you can share with your friends and colleagues. Absolutely tremendous work, and we look forward to hearing from you all soon. Jason, any final words?
No, I must say, I hope all of you are presenting at the meeting in the fall. Fabulous work, truly amazing. Looking forward to getting together in person for a scientific program that features the importance of spinal oncology, as you've just underscored today. Thanks so much.
Thank you, everyone.
Take care.
Happy birthday, Jason.
Yeah, happy birthday, Jason.
Bye-bye.